Hi and welcome. I'm Steve Martorano, and this is the Behavioral Corner. You're invited to hang with us as we discuss the ways we live today, the choices we make, the things we do, and how they affect our health and well-being. So you're on the corner, the Behavioral Corner. Please hang around a while. 3, 2, 1. Hi, everybody. Welcome to the Behavioral Corner. It's me again, Steve Martorano, hanging here on a podcast that we describe as being about everything, because everything winds up affecting our behavioral health. All made possible by our underwriting partners, of course, the good people at Retreat Behavioral Health. You'll hear more about them down the road. We're going to take a look. First, we want to welcome back to the program a friend of the program and a frequent contributor, Dr. Jonathan Beatty. Jonathan is the founder of the Wave Treatment Centers, and we'll find out more about them straight ahead. He is board certified in psychiatry, pain medicine, and addiction medicine. So he's covered the waterfront here on both addiction problems and mental disorders. We're going to take a look at one specifically, which you probably have heard of and think you know something about. I know I thought I did, but I'm learning every day. And that's Obsessive-Compulsive Disorder. You know the old cliches. People washing their hands, opening the door, closing the door. We're going to find out all about that and some of the leading techniques now that Jonathan can share with us on how they're treating obsessive-compulsive disorder. So welcome again to the program, Dr. Beatty.
Thank you, Steve. It's good to be here. And if I may, I just want to, on a little bit of a somber note, kind of dedicate this interview to a close family friend and mentor who I just learned passed away this week. Dr. Imtiaz Ahmad. He was a family friend, also a cardiothoracic and vascular surgeon. He was a pioneer in his field, and he was just a really dynamic individual. He was an incredibly well-educated, learned person who studied everything. He was a Renaissance man in the truest sense, and just had a passion for learning and helped me develop a similar passion. And so I was very saddened to find out yesterday that he had died, and I just wanted to dedicate this to him in his memory.
Well, our condolences, of course. We're sorry to hear that you've lost a friend and a mentor. Anyway, let's talk about the Wave Centers right off the bat for people who might not know. You among the many techniques that you employ in treating all the issues that we've talked about, I guess the specialty at the Wave Centers is TMS. What is TMS?
Yes. So TMS stands for Transcranial Magnetic Stimulation. And what that means is transcranial, meaning through the cranium or the skull, and magnetic, meaning it's a magnetic field. So there's a pulsatile magnetic field, which is able to make its way through the scalp, skin, through the bone and into the brain. So you're able to actually influence the way that the brain signals itself from different circuits in the brain, and it does that through these magnetic pulses. And so there are different target locations for different types of treatment, different parts of the brain that we identify, and then different pulse patterns depending on what it is that we're trying to treat.
Yeah, it's amazing to think of all the that's a pretty thick structure that those waves are getting through, and this sounds like the least invasive technique that you could imagine when dealing with our brain. So it sort of rewires. So TMS is about rewiring the electrical circuits in our brain with a specificity towards certain parts of the brain. And I know you can treat. Well, what sort of things are treated effectively or are indicated for treatment with
Sure.
TMS?
It's interesting because I think we're just scratching the surface, which is what's exciting about TMS as to what it can do. Mm-hmm. But to answer your question, and I guess to bring up the point you made, right, it's the magnet that is penetrating through those structures to get into the brain. It's limited to some extent as to how much depth into the brain it can go. And one of the things that has become more understood in recent past is this brain circuitry, and understanding that there are different parts of the brain that communicate with other parts of the brain, different neural networks. And some of those are superficial, but they communicate with deeper structures in the brain. And so the location of treatment can be a superficial part of the brain, meaning close to the surface, but it's able to then connect with deeper structures. And
Yeah.
so to answer your question of what is currently available, there are so-called on-label device uses and off-label device uses, but in the present, there are several FDA indications. One is probably the most common. It would be major depressive disorder, has very good results for that. Obsessive-compulsive disorder, we'll talk a little more about that as the focal point of today. Anxiety and anxious depression. Those are three big ones. There is a smoking cessation protocol, interestingly enough. There's a migraine headache protocol, and they are looking into whether there are some neuropsychiatric benefits or benefits for those types of conditions, such as Parkinson's and certain dementia. There's a little debate about that because as the brain is kind of aging, there's a lot to be understood about what's happening in those types of brain disorders. But stimulating the brain, this neuromodulation, seems to at least help some aspect of that, and it's probably perhaps a nomenclature that we will redefine over time, meaning that what we see as depression might be a brain disorder that somebody else might see as a component of a movement disorder, which is more obvious because you can see it, or an anxiety disorder or a memory problem. So all these different parts of the brain, I think, manifest symptoms that we cluster together and we call those particular disorders. But I suspect over time, as we identify these brain circuits in better form, we'll have a new set of diagnoses that'll better fit what we're targeting and treating.
Now, I want to get into what a typical TMS session would look like. But before that, it just occurs to me, when you talk about the neural circuitry in the brain, this is a complete sidebar. As they make these leaps, these exponential leaps in the development of artificial intelligence, as I understand it, from a very layperson's perspective, is that these neural networks that they're creating with algorithms are really just trying to replicate the way the human brain works, which is a remarkable thing. I mean, the synapses are snapping all the time, and the brain is communicating to different parts of the brain simultaneously. So they're trying to create. I'm wondering if down the road we won't have depressed artificial intelligence machines. So, do you know what I mean?
Yeah, that's a fascinating concept, actually. And I think I'm not in any real sense knowledgeable about AI other than, sort of in the general sense.
Right.
But I think that it's to some degree almost reverse engineered, meaning that it has the accessibility of all of the literature and all of the information that's out there, that's online. And then it has the ability to identify a human's interaction with a computer, and it can gauge based on that interaction what's going on. I don't know how well it understands which parts of the brain are being activated in that interaction with the computer, with the AI, but it is an interesting point as it, quote, machine learns, if it will learn the human condition, so to speak. Which
I don't see how it could avoid it. I mean, there's no way, if they feed these programs enough information, they won't arrive at a point where you're going to have a lot of very disturbed machines who need to talk to other machines, because
maybe they'll need TMS, because that'll be a way to interface with the robots, right?
Maybe it'll be even easier to administer. Anyway, so just an interesting thought I had there. Then let's talk about a typical TMS visit. It's in your office, correct?
Yes. So this is an office-based procedure. I think what's important to identify, or at least to understand and recognize, is that this is different from a pill or a talk therapy. This is an actual procedure that's accessing a particular part of your brain. So it's very targeted and specific, as opposed to a medication that goes throughout the entire body and some piece of it goes to the part that you're hoping it will. So basically, if I use my handy brain here, the process, there's a chair that you sit in, and the stimulator is right next to that, with these coils, the different types of magnetic coils. And depending on what you're doing, so the initial session is what we call a brain mapping procedure. And the way we deal with that is this kind of red, where is it? I don't know if you can see.
You got to hold it up a little higher. Yeah. That's it.
There, that's the primary motor strip. So that's the part of your brain that controls your movement. So there's a different part of your brain that kind of converts a thought, like, let me raise my hand, into the action of that. So that's more in a deeper structure, the basal ganglia. But the actual motor aspect of it is this part of the brain. And so we can see a movement, we can't see an emotion. So but what we know is that the way a brain communicates for initiating a movement, it's the same signal strength, if you want to call it that, as it would be to alter an emotional state. So we can see a thumb twitch easily. So the left side of the brain controls the right side of the body. So we take a different coil, not the treatment coil, but I'm using my fist as if it were the coil. We place that basically in an area near, well, on or over the part that controls hand movements. And then we look for a little thumb twitch, the adductor pollicis longus and brevis, those muscles that control the adduction of your thumb. When we identify that first by finding it, and then we adjust the strength of the magnetic force or field, and we continue to lower that strength until we get the bare minimum, and then we know that's the exact strength that your brain needs to depolarize to make
so that's sort of calibrating the machine,
right? Or identifying. We're really
the location,
calibrating it to your specific physiology, you as the individual patient getting the treatment. So once we know that number, it doesn't matter what the number is. I mean, it matters clinically, but in our conversation, it doesn't matter. We get that number, and then we typically treat at 120% of that number in a different location, depending on the condition. So for depression, let's say, or anxiety, it would be 120%. And the reason, or the perceived reason for that is, as we move forward and as we age, there are sometimes some cerebral atrophy. So we want to get a little bit deeper than that. So we might need a little bit more than 100% of that. So we go to 120. So we use a different coil that's a treatment coil. We move that by anatomical landmarks. Because of EEGs, there have been probably millions and millions of EEGs. So we have a ton of clinical data about the average skull size and where these different parts are. So there's an EEG coordinate called F3. And so we use a combination of measurements and calculations to identify a part of the dorsolateral prefrontal cortex on that left side. That's where we move the treatment coil, and that's where we place it. So
it sounds like a very precise
it's
technique.
precision medicine. I mean, we're going in the exact target location that we want, and we're identifying the exact dose, if you will, that the patient needs.
When I come in for a session, what is it? Are you providing the technique? Are you doing the technique, or are there technicians? How does that work?
It's a little of both. So the part I just outlined, that's a physician-driven, or at least a provider-driven protocol. And so that's kind of the medical aspect of it. And then once you've identified that, and we also give you a treatment cap. So each patient gets their own, sort of like a shower cap, but it's made out of cloth. We can mark that cap with all these different landmarks. And that gives us the opportunity to, I might actually have one somewhere around here. So these are the treatment caps, and each patient gets their own, and then we keep those for the daily treatments. So once those are on, the technician can put the cap on and know that they're going to hit the same location every time that the physician or the PA has marked. And then they can give that treatment. It's a daily treatment. So depending on the protocol, anywhere from 3 minutes to 30 minutes, let's say, depending on if there's more than one protocol. And that's typically 30 to 36 sessions. So they come in often Monday through Friday, at least 4 days a week, if not 5 days a week. Times 6 weeks gives you the 30 sessions, and then we kind of taper off from there.
So what's the sensation?
A lot of people describe it as a woodpecker, interestingly enough. Not that they feel an actual physical pain, but they just don't know what else to compare it to. And because it's pulsatile, it's not like it's tapping your brain. I mean, it's really the magnets going in and out, hitting the housing, the coil housing. So you hear like a little bit of a tapping, but it's not actually like pushing you but because of that magnetic pulse, you feel sort of a little bit of a stimulation there. And so it's typically not uncomfortable. It should never be painful. People just say it's sort of like because there's really nothing else like it. It's just an unusual experience, but are there any drugs involved in this this process? Not at all. We screen patients. The biggest, but also the most rare risk is there's probably about a 1 in 100,000 or let's even say if it's 1 in 10,000, although it's often cited as 1 in 100,000 patient risk of a seizure. And that would be a self-limited seizure, meaning it would stop on its own and that you would not then have seizures from that point forward. But we do a very careful screening to make sure that you don't have a history of seizures, that you don't have anything implanted in your head. If you're a war veteran and you have shrapnel in your head, that could heat up from the magnet. If you had any sort of surgical implants that were done or cochlear implants that were done, those would be, well, cochlear implants would be a contraindication, but metal clips, depending on what they are, most things are magnetic safe now, they're titanium. So those are not necessarily a contraindication, but they could be. So we screen for all of that. Again, that's all part of the medical evaluation. And then we get you situated in the chair and go through that process, like I said, of brain mapping, and then the actual procedure. You're wide awake. There's no medications. You could theoretically read a newspaper, although more commonly we interact with the patient and try to identify how they're doing. We also, before starting, ask them a few screening questions each day about their sleep habits, their medication habits, their drinking habits, any changes in moods, and so forth. And then we also measure their moods through rating scales at periodic intervals, and that's how we help drive the protocol decisions. If we need to change something, increase the number of pulses, add another location, those sorts of things.
Our guest is Dr. Jonathan Beatty. He is the founder of the WAVE treatment centers, talking about the broad use of TMS. And now I'd like to talk about this. One of the things that caught our attention here, why we reached out to you, you've mentioned that this is a very precise procedure, can treat a number of mood disorders, and you've had some success now with, I guess, a new piece of equipment on the machine so that you can treat obsessive compulsive disorders. If you can give us just a quick thumbnail when we talk about OCD, what are we talking about?
So obsessive compulsive disorder is basically a combination of those first two words. So an obsessive thought is something that is repetitive, that you have frequently over and over again. You may not have any control over it. In some of the older kind of Freudian literature, they would refer to either ego-syntonic or ego-dystonic type of obsessions. And what those mean in kind of present day is, are the obsessive thoughts troubling to you? Like, for example, it could be an obsessive thought that there are a lot of germs. So germ fear or infestation, these kinds of things are sometimes one of the types that occur. They're to some extent distressing, and they can be very distressing. And there's often then a compulsive behavior, and we'll get into that next. But the obsessive thought could be some horrific thing, like thinking about somebody dying or something that you would never actually think in your own personality, but yet you have this thought, and so it's very distressing or dystonic. So that's what that means. So you have these obsessions. They can happen throughout the day. They can happen for multiple hours per day. And then there's often some type of compulsive behavior, which you typically will try to do in order to alleviate or reduce this distress. So the hand washing, I think you mentioned as we started, that's a common one. So if you touch something and you think that it's dirty or that you're now contaminated, this fear of contamination, you have to wash your hands, and you might have to wash your hands in a compulsive way. Like you might have to wash 5 times, then soap again, then 5 more times, something like that. People have various things like evening out, some people will call it. So if they touch something on the left, they have to touch something on the right. They have to touch, if they walk on a sidewalk and they walk on a crack, then they have to walk on a crack on the other foot, like these sort of balancing things. So those kinds of things are just some basic examples of OCD.
Yeah, it's easy to see how it's I'm sorry.
I just want to quickly differentiate that as a pathology to what a lot of people are sort of colloquially refer to as OCD, right? So like, okay, I have OCD, so I need to like wash my hands or something. That's not really what we're talking about. This is a much more severe level and in the most extreme sense, people might have raw skin because they've washed their hands so much, or even burns because they needed to use such hot water. So it's really a much more severe thing than just, a low level type of distress.
Yeah, or it's certainly not. It's certainly not the. Hollywood has a tendency to take diseases and make them Hollywood diseases, where people never seem to lose weight when they're ill, and there's been depictions of people with obsessive compulsive disorders that make it seem like it's kind of quirky. That's all. We're not talking about quirky. We're talking about behavior that can ruin you, not ruin, but certainly disturb your life.
Generally speaking, yes. Now, there is actually a differentiation to something called obsessive-compulsive personality disorder, which depending on the level of severity might be more like what you're talking about, which is a little bit more quirky, a little bit less flexible. And so, yeah, people are like, oh, well, he just, can't, or she can't just adjust to something on the fly. They need it to be, that's a little bit different.
But it's not paralyzing in its impact.
The best example I can think of in relatively modern cinema would be As Good as It Gets with Jack Nicholson. He does a great job. If anybody hasn't seen that, you should watch it. It really does depict OCD very well.
Yeah, Tony Shalhoub, the terrific actor, has a series where he plays, I guess, an investigator, Monk. Yeah. And he does a pretty good job with it. So tell us now. Oh, by the way, how common is OCD?
I don't have a statistic on you. I should have looked that up for you rather ahead. I think that it's relatively common among psychiatric diagnoses. So that's obviously a selection bias. People coming to see me, they've already been troubled by whatever's going on in order to come see me. So in the general population, obviously that would dilute that frequency quite a bit. But I think it's among the more common disorders, I would say. But I don't want to misquote an exact number.
Jonathan, what's new about what you guys are doing at the Wave Centers?
Sure. So the OCD protocol uses a slightly different magnetic coil. So we have a different, and that was more recently approved by the FDA or cleared by the FDA to be used for treating OCD. And so the target is different. So that motor threshold that I described for a thumb twitch, instead we use a more central, towards the vertex, or towards the top of the brain, part of stimulation for the motor threshold of a toe. We look for a toe twitch, actually. So we have the patient has to take their shoe off for that one visit in order to look carefully at their toe and then we identify the same strength, same process. And then we're treating a deeper structure. So we need to increase the intensity. So that's one of the reasons that the magnetic coil is a different coil, is that it has the capability of penetrating deeper down into the it's still a relatively anterior approach. It's more or less the dorsomedial prefrontal cortex is the location. And other than that, it's basically the same. One other difference is, the protocol is basically the same. It's 100% of the motor threshold rather than 120%. The number of treatments, the number of pulses is a little bit different. What they call so a series of pulses is called a train. So if you have 5 or 10 or 15 of these pulses, then there's an interval between them called the intertrain interval. It's a much longer intertrain interval for that protocol. These are kind of, not that interesting probably in a conversation, but they have clinical relevance.
And the process is the same 6-week
exactly
process?
Yeah, exactly. It can be a little shorter sometimes for the OCD, but typically it's about the same number of sessions.
And then just as follow up on treatment, while this is going on, while the 36
30 to 36 treatments depending on.
Is there any, you've mentioned that there are no drugs during that process. Is there a component of talk therapy that also goes on during these sessions?
Yes, and actually I should just back up to clarify that although this treatment and this procedure doesn't require or doesn't involve medications, the typical patient that we're seeing has already not responded to a number of medications, and that's a sort of refractory disorder in that sense, that it hasn't responded to, depending on which insurance company you're talking to or how you define it in the literature, anywhere from 2, well, Medicare actually 1, but one medicine, but usually 2 to 4 medications for that condition. So SSRIs are the most common. There's a couple TCAs that are associated as tricyclic antidepressants. These are the meds that are most commonly used to treat OCD, similar medicines to treat depression and anxiety. And they are often ineffective at treating the OCD. So this is kind of a more robust treatment for it.
Yeah.
To answer your question, therapy, that they may have not responded well to talk therapy or psychotherapy as another indicator of why they need the OCD. whether or not you incorporate psychotherapy into the TMS sessions, we try at least at a minimum to provide some sort of supportive psychotherapy. So depending on whether there's a clinician present and versus the technician present, obviously a technician doesn't have the level of psychotherapy training that a clinician has, but on some level, there's obviously a supportive element to this and trying to understand kind of since we're talking about the OCD, what are the obsessions? What are the compulsions? And then how are they affecting you and how are they improving, hopefully?
Yeah.
Treatment.
Particularly that last point. Obviously, it's inherent in the whole thing. This is when, they show up and how you do it.
Right.
And this final question on OCD, it strikes me as that it might be common, or not so uncommon anyway, that people don't recognize they have a problem with this kind of behavior. And I would guess they get to you when other people say to them, you gotta find out what's going on here. You're doing some stuff it's very peculiar. In other words, do people know they have this disorder?
I think that not always. I mean, there's definitely a subset of patients with any psychiatric condition where they're just like thought that was normal, and then somebody described it. Or I've had situations where somebody has talked to a friend even, or somebody else and that friend maybe got diagnosed with it and had this distress over it, got the diagnosis, got the treatment, and was explaining it. And then the soon-to-be patient was like, I have that same thing going on, and come to find that it is something like OCD or it's one that's, if you're depressed, it's usually a little more obvious. Maybe if you have obsessive thoughts and the compulsions are also thoughts rather than actions, then it's not as obvious. I mean, you can see somebody washing their hands 10 times a day and be like, that's something's going on there. Let's ask what that is. One of the things that's helpful, I just wanted to bring up, I mentioned rating scales. There's one called the Y-Box, the Yale-Brown Obsessive-Compulsive Scale. That's a kind of industry standard rating scale. It's well tested, normalized across populations and so forth. And by the way, I did quickly just glance. I think 1 in 40 adults in the United States can be diagnosed potentially or have OCD. So it's pretty common.
Pretty common, yeah.
I won't go through this whole thing in detail, but on a cursory level of this symptom checklist, they break down the obsessions into aggressive obsessions, contamination obsessions, sexual obsessions, hoarding and saving obsessions, religious obsessions, obsessions with need or symmetry or exactness, and miscellaneous. Also somatic or body experience, cleaning and and then compulsions. There are cleaning and washing compulsions, checking compulsions, like having to check the door a certain number of times, or the lock and the handle, whatever.
Right.
Rituals, counting compulsions, ordering and arranging compulsions, hoarding and collecting compulsions, and miscellaneous. And
what's the name of that scale?
That's the Y-BOC, and that's Yale-Brown Obsessive-Compulsive Scale.
Dr. Beatty, thanks so much. We appreciate this. Jonathan Beatty, founder of the Wave Treatment Centers. If you want more information about them, they have a terrific website, and you can check them out there. It's just wavetreatmentcenters.com. Yep. So WAVE treatmentcenters.com. Yep. We'd love to speak to you if you have a need. So give us a call. Jonathan, thanks so much. If I don't see you before the holidays, have a great holiday, and I hope you'll join us in the new year as well.
That would be great, Steve. Thanks so much. It's great speaking with you.
Take care of you guys as well. And don't forget to like us, follow us, subscribe to the Behavioral Corner. We'll see you next time. Bye-bye.
Retreat Behavioral Health has proudly been serving the community for over 10 years. Here at Retreat, we believe in the power of connection and quality care. We offer comprehensive, holistic, and compassionate treatment from industry-leading experts. Call 855-802-6600 or visit us at www.retreatbehavioralhealth.com to begin your journey today.
That's it for now. And make us a habit, hanging out at the Behavioral Corner. And when we're not hanging, follow us on Facebook, Instagram, and Twitter on the Behavioral Corner.